Welcome to Meet the Partner, Saving Lives in Partnership with Pharmacy Leaders. My name is Jeff Bornstein, and I'll be running this Dialogue for Health web forum with my colleague, Merlene Tucker. We want to thank our partner for today's event, the National Overdose Prevention Network. Now it's time to meet the moderator of today's event, Dr. Carmen Rita Navarez. Dr. Navarez is the director of the California Opioid Prevention Network and the National Overdose Prevention Network. She's the Public Health Institute's Senior Vice President of External Relations and Preventative Medicine, and the Director of the Center for Health Leadership in Practice, and the Director of Dialogue for Health. Carmen, welcome. You have the mic.
Thank you so much, Jeff, and welcome to everybody for joining us. We're really very excited about today's session, and so let's just go ahead and get on with it. Before we get started, I want to cover today's learning objectives. This is a 30-minute session only, so we'll try to just get into the questions as quickly as possible. We want to introduce the National Overdose Prevention Network, identify the role of healthcare partners in overdose prevention, and explore how to build effective partnerships with pharmacy leaders. Next slide. Thank you. So we created the National Overdose Prevention Network, or NOPN, in order to share what we've learned from the California Statewide Overdose Prevention Learning Network. And that's that people working on the ground need stronger partnerships, proven strategies, and resources in order to prevent overdose deaths. We start with partnerships and the need to bring diverse partners to the table and support working across sectors in order to truly leverage all of the assets that are already present in your community. We want to inform those discussions with strategies based in evidence and align with preventing new addictions, managing pain safely, treating addiction, and stopping overdose deaths. We've learned much from thinking through work that has been tried across the country and engaging with people across the country who are also leading the work, as well as offering you, our listening audience, a chance to participate through questions in the Q&A that we're inviting throughout this presentation. Can I have the next slide? So let me introduce our speaker. All right, good. Dr. Gasper is a psychiatric and substance use disorder pharmacist for the California Department of Healthcare Services. He received his doctorate of pharmacy from the University of Colorado Health Science Center and completed his specialized residency in psychiatric pharmacy at the University of California, San Francisco. He spent the last 15 years establishing programs providing direct care for patients with opioid addiction, stimulant use, and other substance use disorders, with a special emphasis on the comorbidity with mental illness. So I'm really pleased to invite Dr. James Gasper to be in conversation with us. Thank you so much for attending. Would you be
Thank you.
Would you be willing to start off by telling us about yourself and the role that you play in the intersection of pharmacy and addiction?
Absolutely. Thanks for having me today. You know, when I got started in psychiatric pharmacy, it's been a little bit over 15 years now. The first thing that I noticed is that we couldn't treat mental illness unless we stabilized addiction, and we couldn't stabilize addiction unless we treated mental illness. The idea of treating co-occurring disorders at the time was fairly novel. There was a lot of siloed thinking, both on the mental health and on the substance use disorder side. And I wanted to kind of bring those two together. So it was kind of a logical step for me. I realized that in order to get to the end point of, treating treatment-resistant schizophrenia, we had to stop people from using methamphetamine. So that's kind of how I got down this road.
Well, that's very important to this conversation. It sounds like you just sort of landed in the exact right place at the right time in your career to help blossom your interest and your scholarship. When we think about pharmacists being key partners to prevent overdoses within communities, can you share more about why pharmacists should be at the table and suggest some successful strategies for getting them there and keeping their interest in our work?
Yeah, and particular when we think about community pharmacy practice, pharmacists are really at the intersection of the healthcare system and people's lives. People are in and out of pharmacies every day. They come and pick up their prescriptions, they pick up other essentials that they need, and the pharmacists are able to see what's going on in their real world. Now, many of you may be aware that when patients walk into their doctor's office and they're on their best behavior, if their agenda is to get a refill of their prescription opioid, they may present their best self under those circumstances. But in the community pharmacy, it's not usually that way. That's who sees them waiting outside the pharmacy before it opens, looking for their refill or considering, asking for an early refill, or they show up intoxicated. A lot of their life exists in the pharmacy. So pharmacists are really, I think, fantastic partners in this process because they see so much more of what's going on, from that perspective. And, your second question is how to include them in it. Well, there's a lot of ways, in community pharmacy is not the only place that pharmacists work. They're both in the emergency department and the hospital. They do direct patient care in clinics, but most, people probably interact with their community pharmacists. And it's a great place to make them part of the care team. When I think about medications like buprenorphine, it's probably the only drug that patients will chronically refill with a short day's supply. We give people 7 days worth of buprenorphine with refills. There's no other medication that's dispensed that way. So the pharmacists have a lot of contact time with patients in a way that doesn't really exist for other medications. So they get a lot of face time with them. They get to see them over and over and develop relationships. So by making them part of the care team, they can provide, valuable feedback to the prescribers and to, their substance use counselors and other people that, are helping them, progress through recovery. I'll also say that pharmacists are there to help people that are looking for drugs like naloxone or sterile syringes, or might be getting in trouble, with their prescription opioid. Pharmacists really the first people to see and to respond to those needs at the community level. So it's important that they're part of the conversation.
Yeah, that's really true. I think you've painted a very really a very brilliant picture. And now that I'm thinking about it, it's certainly a picture that when we're doing this work on the ground, we sometimes fail to understand how close that contact is between the clients that we most want to serve and the place that can be either life-saving for them or even more dangerous. So that was very helpful. Would you be able to talk a little bit about what are some of the challenges from the pharmacist point of view, or maybe some of the pushback issues that make it difficult for them to participate in this work with us?
I think one of the points of friction and frustration is the community pharmacists, because they are seeing patients, in this day-to-day life and seeing not just their medications from one prescriber, but from many prescribers, they have a really good understanding of what's going on with them. And when they reach out to express concern about a dangerous drug combination or dose or regimen, they may not get the support. So patients say, I want to continue on my prescription opioid at this dose. Please don't interfere with it. The prescriber just wants to continue with it. So they often get pushed aside, even though they're actually at an important position to intervene on that. So I think they need to be listened to. And in many ways, we need to rely upon them, to be our eyes and ears and to make those judgment calls in the front line. And we need to support them in doing that. It's a very important step to do. And I think part of their frustration is it doesn't happen.
Mm-hmm. So there's sort of two paths to go here. One, and I'm going to ask you to answer both of them. One is, could you suggest some ways for us to better interest our community pharmacist in being engaged in overdose prevention work with coalitions, with, with local people? How can we get them interested? And then also on the other side, what are some strategies for looking at this from a corporate perspective? How do we get the larger corporations to buy into this as an agenda for them?
Yeah, and I'll address the second one first because it's a little bit easier. A lot of what happens in pharmacies is based on corporate policy. And surprisingly, when naloxone was beginning to be rolled out in California, and I'm speaking of Pharmacists furnished naloxone, and we're about 4 years into this now, it was the corporations that put it into their training protocol and actually operationalized it for the pharmacists there. So they've actually stepped up and have been really good partners at putting some of these things together. And you can even hear the advertisements now if you walk into a community pharmacy. Do you need naloxone? Are you concerned about opioid safety? Like, these things are part of a very long wish list that I think they stepped up and participated in. And I'm very excited about that. So I think they have been part of it. They've also been part of this prescribing agenda. And it's important that, we understand that the pharmacy corporations are trying to support the pharmacists in making safe decisions about how prescriptions are dispensed. So they put policies in place for that to stand behind them. On the other side, how do coalitions get pharmacists involved in this? I think the important thing is to reach out to them, and you'll find pharmacy champions. They exist in every community, and they work inside FQHCs, and they work in hospitals, and they work in community pharmacies. And the best person to reach out to a pharmacist is a pharmacist, because we speak pharmacy. And that's something that I've spent a lot of time doing, and it's the usual stuff. It's motivational interviewing and academic detailing. I go in and I talk to pharmacists and say, look, you can be part of the solution here. We want you to participate in this. We're going to have people coming in on buprenorphine. They are going to need a lot of help and support, and we're going to rely upon you to give us feedback on that. So I think really empowering them goes a long way.
Mm-hmm, mm-hmm. We're starting to get some really good questions from the audience, and I want to ask the audience to please keep the questions coming, and I'll do my best to incorporate as many as I can. I want to just pivot a little bit and talk about COVID, because COVID has certainly changed everything about how we do things on a daily basis. It's just evolving, and things are changing again very quickly. What do you think has been the impact on COVID for pharmacy, and how has that stimulated some new ways of working together?
COVID has been interesting in that I think the whole healthcare system, when we look at our routine disease prevention services, patients basically stopped showing up a year ago. They stopped going into primary care offices, and they stopped taking their, diabetes medication and their hypertension medication. So we've seen a lot of people disappear, and from pharmacy practice for that reason. But on the other hand, and this goes back to my earlier point, now that they're only receiving telehealth services by and large for these chronic conditions, guess who is actually seeing them? The only healthcare provider that they're in contact with or have been in contact with has been their pharmacists. So for the last year, they've been calling in and they've had these video telehealth visits, but nobody's actually seen them in person. And I think it's important. Telehealth has done a great job of extending access to care in remote areas and providing it when otherwise we wouldn't be able to. But we still need to lay eyes on people. I consulted on a case where a buprenorphine patient got telehealth visits, and she ended up delivering a baby and nobody knew about it. So she didn't receive any prenatal care because in the telehealth process, nobody was they were probably more like telephone visits. Nobody was actually aware of that she was pregnant or that she was almost due to deliver. So having eyes on people is very important. And again, people are still showing up to pick up their prescriptions, and they're still being seen there. So I think they've even played a more critical role.
Uh-huh. that's a really good example, and it really sort of again, it paints the picture of what it's like to have that face-to-face opportunity, and there's no question that you can't hand the drugs over, can't hand medication over the phone. So
yeah, and we have switched to mail order delivery, and there's been some other modifications that have been made, particularly early on in the pandemic, because people were scared to walk into pharmacies. But I think by and large, they're picking it up from their their community pharmacy, on a monthly or more often basis.
So there's a very interesting question that's come in, and I'm going to share it with you. There's a barrier to pharmacists prescribing buprenorphine. How do you manage or work around this barrier? Do you expect the restrictions to change to allow pharmacists to obtain an X waiver?
I do. I think the X waiver will be removed. There's clearly was some movement in that direction with the previous administration, and everything is pointing in that way moving forward. So I anticipate someday we will be able to. Currently, we've actually developed a collaborative practice agreement that was signed off by the California Board of Pharmacy that allows pharmacists to initiate and modify buprenorphine in collaboration with an X waiver prescriber. And it's on their website, and it's available for any pharmacists in California to use. So there is a way that we can partner with X waiver prescribers to participate in buprenorphine care. And this isn't so different from what mid-level practitioners were doing before they were granted access. NPs and PAs did buprenorphine management 15 years ago. And they've been, really fantastic at doing the monitoring and the follow-up, just not the actual prescribing. And pharmacists can do that today. There's no reason that we can't. And that's a lot of what I've done, in my practice, is just seeing the patient, making decisions about their care, and collaborating with their, X waiver prescriber.
Do you think that health information exchanges have a role to play in the setting of pharmacy and pharmacist involvement in addiction and substance use disorder management?
I think it's touchy because of the privacy walls that are put around substance use disorder treatment. And we've bypassed a lot of them in primary care by incorporating it in the mainstream medical practice, but it's always going to be sticky when we talk about SUD treatment.
Yeah, it's a good point to make. I think that's a privacy is something that gets even more sensitive when we start talking about substance use disorder. Yeah.
Yep.
So for states that will not implement a co-Rx mandate for physicians, are pharmacists willing to provide naloxone prescription if they're presented with an opioid prescription? Is there a pharmacy authority for naloxone?
Yeah, so in many states, pharmacists have the authority to furnish naloxone to anybody that shows up. Beyond that, kind of coming back to the corporate policy that we're discussing earlier, some of them actually have policy that patients on a certain opioid MME are required to have a naloxone prescription on file. So there is some protocol that's being done around this, and there are some best practices that pharmacists are following. In general, I think it has to be a case-by-case basis, because if you just hand out naloxone to everybody that gets, 10 hydrocodone tablets, nobody's going to take it, and it's not going to actually go to where it's needed. But for patients that are looking for sterile syringes, for those that are on high doses, those with COPD and other high-risk groups, I think pharmacists are in a great place to kind of make the decision. This is somebody that should have naloxone, and I'm going to talk to them about it and let them know why I'm worried.
This is a very on the ground question. We have the highest opioid prescription rates in LA County. How can pharmacists help to deal with this problem?
That's a systemic problem. I think, as being the final check in the drug distribution process, I think pharmacists are really critical in making sure that two things. One, that patients are able to access opioids for analgesia. So for those that have had an acute pain syndrome, we want to make sure that we're preserving access to opioids for them. And number two is for patients that have been on opioids, we need to make sure they don't get fired and kicked off of them, because we know what happens there. So really, I think the pharmacist's role is kind of opioid case management, and that making sure that we're using it in the right places. And there's been a lot of changes in medical practice to ensure that. But I think at the end of the day, we're at the end of the line, when these decisions are being made, and we need to look at the person in front of us and make sure that we're using the opioids for the right reasons. Mm-hmm. And also that we're not making unsafe decisions about their care.
Mm-hmm. So are there any drug distributor programs that offer grants or would pay for smaller independent pharmacies to go the extra mile in prevention and education? You aware of any of those?
Not that I'm aware of.
Mm-hmm. Sounds like an opportunity for some of the maybe for some of the state boards, but you would know way more than I. So many pharmacies are part of a national company. How do we involve them when they have to go back to their corporate supervisors for any commitment that they might make?
Yeah, you got to start at the top, and they're all broken down regionally, and that's kind of how I approach it. They have regional managers and they have district managers, and those are the people that make these decisions that then get pushed out into the community pharmacy sites, and I find them very easy to work with and supportive of things that we've done. I actually believe the challenge is getting the information from them down to the front line, so it kind of goes both ways. Mm-hmm. You may want to speak with somebody locally and say, why, can we change this policy? And they have to bring that up their management chain. But also when we talk to their management chain, they have to bring it down to the store level for it to be implemented. So the communication there is important.
Mm-hmm. Do you think that any of the opioid lawsuits that are in progress start to provide significant incentive for the chains to participate in behaviors, policies, and practices that would support a safer environment for people that are taking substances with high risk for addiction?
I think it already has.
Talk a little bit about that.
So many of the existing policies are actually more stringent than what pharmacy benefit managers are doing. For example, there may be a pharmacy policy that limits new prescription opioids to 7 days and a maximum of 50 MME per day. The pharmacy benefit manager may allow for 10 days and 100 MME. So they already have policies in place, and some of it is in response to the lawsuits around opioid distribution and the overdose deaths. So this has been done, and it's been in place for a number of years now. Mm-hmm. So they have responded to that.
So a really good harm reduction question came up, and I want to get your thoughts on whether you think it's a good idea to dispense sterile water for harm reduction.
Yep. Sterile water, clean cookers, tourniquets, spark plug boots, everything. Yeah. One of the issues is that most of those can only be legally dispensed from certain service programs in California. We can't keep them in pharmacies. I think some do, and we should. But in terms of harm reduction, all of that's critical, to reduce bloodborne pathogen transmission in our injection drug community.
Mm-hmm, mm-hmm. At risk is so subjective. Is there a tool that helps pharmacists define and identify all at-risk patients? I assume we're missing many at-risk patients as more and more folks are overdosing and dying.
Yeah, and I'll kind of take it a step further and say that we're no longer looking at the highest risk. 10 years ago, it was their prescription opioid. Today, it's the fentanyl and the heroin that's on the street. And we don't have direct contact with that. So we used to be privy to their, risk factors for overdose death. And now it's happening outside of the medical system. And we may see people looking for, sterile syringes or showing up with track marks or intoxicated, but that's it. We're only seeing the symptoms of the illness, and we don't have a lot of insight on the other risk factors.
Well, we're just about at the end of our time, but I wanted to ask you one last question. And I'm sorry I didn't get to everybody's questions, but I want to compliment the audience on sending up such good ones. Do you think that things are going to change at all with the new federal administration? Will there be more of an understanding around overdose and a finer attention to progressive policies that could really help us to fight overdose deaths?
I think we're all optimistic that this is something that will be picked up on. I think the COVID pandemic has taken us away from that for the better part of the last year. But something that everybody may be aware of is that our overdose rates have spiked dramatically. The numbers are scary to look at. They're probably 4 times higher than what they were pre-pandemic. And I think very quickly we will move back to address that. We're really going to be in a difficult position coming out the other end of this pandemic in terms of overdose rates and addiction treatment.
Right. Well, let's keep our fingers crossed, and let's keep the cards and letters coming, and as soon as we can be out there, helping people to understand what the issues are and helping them to change federal policy. So I want to thank you so much for this great session. You just, you touched on so many issues, and clearly there are so many more. But I also want to turn away from this just for a second to see the next slide and to have everybody aware of the fact that we're going to do one more in our special series on trauma-informed practice with Brooke Brigance. And that would be Wednesday, March 24th from 11:30 a.m. to 1 p.m. and that's Pacific time. So you can come back to our site and just get, login information and registration information from us there. And then last slide, please. Okay. I want to just take a minute to remind everybody that NOPN is here to serve you. We're excited to be working together to build this national learning community so that we can really connect and learn from each other, hear what your issues are, hear what our issues are. Let's see what we can, what kind of intelligence, what kind of ideas, and what kind of practice we can bring to this discussion. So please sign up for our digest and stay tuned to our webinars, our website, and the programs so that we can help advance your work. We really want to learn from you as well. So please send us your ideas for future website, for future webinars that would be of interest to this group. The slides and recordings are going to be available both on the NOPN website and on the Dialogue for Health website within the week. Go to NOPN, that's NOPN.org to contact us and to sign up for our newsletter. And thank you so much for joining today's discussion. Goodbye, everybody.